antimicrobial resistance will actually undermine our progress towards universal health coverage, and not only it strains the healthcare system, but it also incurs huge loss on the patient at an individual level. In one of the plans which was released by UK government, it has expressed major concern over management of infections, because according to the UK government, it has identified infection care as one of the biggest concerns, as 1 in 5 hospital beds in England are occupied by patients with infectious diseases as a primary cause, costing almost 6 billion pounds annually. In India also, we see a huge number of infections in our hospitals, some community acquired and some hospital acquired. An emergence of AMR actually compromises the management of infections. To be able to manage infections better, we need to understand the trends and the levels of resistance. And that we accomplish through the AMR surveillance. So ICMR's AMR Surveillance Network was designed with a similar intention, that it should be able to provide us the real-time evidence on the resistance patterns. It should help us detect the high-resistant pathogens and outbreaks in earlier to prevent damage, and also it should be able to guide the infection control as well as the antibiotic stewardship programs. ICMR has been running this network since 2014, and for a long time this network was limited to tertiary care hospitals across the country, and we've been publishing annual reports since 2017. But this year we have expanded our network to include data from secondary level hospital as well. And the next year's report will, in all likelihood, also present data from the secondary level hospitals. Many of the hospitals who have been part of ICMR's network since 2014 are also initiating this activity at their level of mentoring these hospitals to report quality data. So now with this, I request my colleague, Dr. Nitin Bansal, who's here. He will present the highlights of the AMR surveillance report this year. And just one housekeeping announcement, that kindly, for all the participants, that kindly add your questions to the chat box, and we will be taking questions from there. So over to you, Dr. Nitin.
So, good evening, everyone. I hope my slides are visible and I am audible to everyone. I would like to thank Madam and her team to give me the opportunity to present the highlights of this year's report. I am actually presenting the hard work of many stalwarts from the field of microbiology. So it is indeed an honor for me to present these highlights. Next slide, please. Next slide. I have a disclaimer to make that I will be mostly presenting these highlights from a clinician standpoint. The report also has a lot of inputs from epidemiology point of view, public health point of view, and obviously from the microbiology point of view. My interest is primarily from the clinician's viewpoint. Next slide, please. So after a lot of deliberation and hard work, we came out to the classification of various important pathogens from the Indian standpoint, and these were the classifications which were given: Group 1, Group 2, and Group 3, and the action required for containment for each of these were given as aggressive action and continuous monitoring. As you can see from this, this classification, what is more important is that we need to understand that for aggressive action, we have classified CRE and CRAB as are the top pathogens, whereas the other pathogens which are important from the other parts of the world, like Staphylococcus aureus or fungi pathogens, were given lesser interest to this. Next slide. So this year's highlight, they basically data comes from tertiary care hospitals, and we have analyzed close to 1 lakh isolates, 99,000 to be precise, and most of them are gram-negative. This is basically dominated by gram-negative bacilli, and 72% of the healthcare BSI are secondary to gram-negative bacilli. As expected, E. coli is most common, followed by Klebsiella, and there is use or rising carbapenem resistance, as we will highlight in subsequent slide as well. Gram positives are relatively less. The number of gram positives totally are very less as compared to gram negatives, and the MRSA rates are also supposed to be increasing, like from 33% to 53% over the course, or the trend is towards increase from 33 to 53% from 17 to 2024. And there is a emergence of H. visa, that is heteroresistant vancomycin intermediate Staphylococcus aureus, which is also concerning. Rest of the trends will be discussed in the subsequent slides. Next slide, please. So in order to understand and give a more clinical implication to these highlights, I will discuss few cases. Just keep on moving in the cases. This is just a case from my hospital who has undergone a nephrectomy for renal cell carcinoma, 60-year-old gentleman who has had past history of tuberculosis and fibrotic changes in the lungs. And on post-op day 4, he got shifted back to ICU for fever, shortness of breath, and hypoxia. Next slide. And he gets intubated in view of worsening hypoxia and increased work of breathing. This is his pre-op X-ray, which is there on the left, which you can see some fibrotic patches on the right, on the left apical area. The rest of the lung fields are fairly okay. When he gets intubated, when he gets worsened, he develops new infiltrates into the in the right lower half of the lungs. Next slide. So clearly, there is no doubt that we are handling here a hospital-acquired infection, and most likely the source is the lung. And he has received piptazo as a surgical prophylaxis for 48 hours. So what is the empirical choice of antibiotics in this scenario? Group 2 carbapenem, that is mostly meropenem or imipenem plus a vancomycin or teicoplanin, or should we go with polymyxin B, or should we go ahead with the newer combination of casavy-estonam or some other drug combination? These are the general choices which we have as a clinician to decide when we try to treat hospital-acquired infections. Excellent. So in order to answer this question, this answer can be given from the current ICMR report, which clearly shows that the top 5 pathogens are predominantly gram-negative, dominated by E. coli, Klebsiella, Pseudomonas, and Acinetobacter. And if you look into hospital-acquired pneumonia syndromes, then the most common pathogens are gram-negatives only. Acinetobacter tops the list, followed by Pseudomonas, Klebsiella, and Pseudomonas. Next slide, please. So automatically the choice containing vancomycin, and just keep on moving the slides. Automatically choice containing vancomycin and teicoplanin is out. We don't prefer giving casavy-estonam because Acinetobacter is a top pathogen for pneumonia in our hospital also, and also as seen in the network, most common cause of hospital-acquired pneumonia, which this drug combination does not cover or fails to cover. So automatically the choice becomes a group 2 carbapenem plus polymyxin B as a go-to drug for treatment of hospital-acquired syndromes or hospital-acquired pneumonia. Next slide. So for this patient, unfortunately, what we grew was a carbapenem-resistant Acinetobacter baumannii isolate, which was colistin MIC was reported as 2. It was sensitive to minocycline with MIC of 2. TG-cycline was reported as sensitive with MIC of 2, and it was Septran was also sensitive. Dr. Yatin. No, Dr. Yatin. Okay, next slide. So we started him on meropenem polymyxin B empirically in view of hospital-acquired pneumonia syndrome, but as the colistin MIC was 2, we shifted the patient to PMP SMX and high-dose minocycline, which showed good clinical improvement, and total days of therapy was given as 8 days. Next slide. And you can see from the X-ray, there was a good resolution in the infiltrates as well. Next slide. So in this report, you will see that the Acinetobacter baumannii isolates. Next slide. Susceptibility to minocycline is close to 70%. So apart from polymyxin B or colistin, the only reliable antibiotic working for Acinetobacter baumannii is minocycline. And as expected from the genomic study of these isolates, most of these isolates have they are carrying NDM as well as OXAF23 as a co-carriage, and which basically signifies high level of resistance to most of the antibiotics with Acinetobacter throughout our country. So polymyxin B plus minocycline remains the only or mostly reasonable treatment option for treating serious carbapenem resistant or CRAB infections pending new drug availability. Next slide. Case 2 is a 32-year-old gentleman who has been previously healthy and who has had fever for 2 days, which subsided on its own, and subsequently diagnosed as having AML, got admitted and started on chemotherapy. And during next slide. He at day plus 10 of admission, at day plus 10 of after chemotherapy, develops high-grade fever with chills, with no major localization on history examination, with mild mucositis, and he is neutropenic as well. Next slide. After taking 2 bottles of blood culture, he was started on cefepozin sulbactam, and next day, because of non-relenting fever, he was shifted to meropenem. Next slide. Fever is day plus 12 fever was better. Culture has grown E. coli, and it was a fairly sensitive strain. There was a failure to de-escalate from the team, and he was continued on meropenem in this case. Next slide. 5 days later, he was okay, but at 5 days later, he started having high-grade fever with chills, and as you can see from the chart, he was literally febrile the whole day for 24 hours with extreme tachycardia and borderline vitals. He was still neutropenic, and there was a lot of mucositis. He was currently on meropenem. Next slide. So we added polymyxin B, considering that he is at high risk of developing CRE infections. And next day, culture flagged as gram-negative bacilli. Next slide. So final culture report showed Klebsiella pneumoniae, which showed sensitivity to fosfomycin, intermediate sensitivity to imipenem with MIC of 2, and sensitivity to polymyxin B and chloramphenicol. Next slide. So patient was already on meropenem and polymyxin B. We spoke to the oncologist, who said the TLC will take another 4-5 days to recover, but the patient was persistently febrile. Next slide. So what should we do? Should we continue same? Should we stop meropenem and add high dose imipenem along with polymyxin B, or we shift to Cazevi estonam combination, and or is there, or do we have some other idea? Next slide. So in order to answer this question, this answer can be very clearly answered from the recent ICMR report, which, as you can see, most of the Klebsiella isolates, this is a holistic genomic surveillance report of the Klebsiella isolate, which shows that 25% of the isolates have OXA48. But if you look into per se only carbapenem resistant isolate, then close to 50% of them will be having only OXA48. Next slide. So it is worthwhile basically to do a genomic gene testing or enzymatic or do a test which can test the enzyme, the kind of enzyme which the carbapenem resistant enterobacteriosis is harboring. In our case, the isolate was an OXA48 producer, and we could actually shift the patient alone to Cazevi estonam. Only Cazevi, and after which the patient improved. It is also possible that quite a few significant number of isolates might have MBLs in combination or in combination with OXA48 or alone, in which case estonam is the go-to drug after demonstrating in vitro susceptibility. If that is not available, then polymyxin B based combination therapy can be given. Next slide. Just move on. Next slide. Move on. So right now it looks like that I have been discussing too much about resistance, but I will also show some cases where resistance is not an issue. Next slide. So this is a young boy who is a son of doctors. One of them is a medical oncologist, and another one is a critical care specialist. These are the specialties which actually face the current of AMR, and they handle a lot of patients who are having a lot of resistance also. Their antibiotic prescriptions are quite they are not reluctant to escalate antibiotics at spikes of fever. So their own son got admitted with high-grade fever with chills, with poor oral intake and intermittent abdominal pain for last 7 days. And on examination, he was febrile with features of dehydration, so he was admitted. His systemic examination was normal. There was no systemic findings, and his basic blood test was also normal. His TLC was normal, and left showed mild transaminitis. Next slide. Next slide. Next. So in view of a working diagnosis of acute and differentiated febrile illness in a young boy was kept. And next slide. Just keep on moving. And fever was almost for more than 5 days. So respiratory viral illnesses and illnesses like dengue were ruled out. Since basic labs were unremarkable, so except for eosinopenia, so working diagnosis of ventric fever was kept, and he was started on ceftriaxone, azithromycin, with a probable clinical diagnosis of ventric fever. Next slide. The next 2 days, he remained febrile. Culture did not flag for 2 days. So the treating clinician, that was myself, was under immense pressure to shift the patient to higher antibiotics like BLBLI or carbapenem, because of various reports of ESBL salmonella or even carbapenem-resistant salmonella being released from various parts of the country. So finally, we had a next slide. Finally, the culture flagged and it grew Salmonella typhi, which was sensitive strain. Next slide. Next slide. As you can see from the report, also from this current ICMR reports, and you can see from the trend as well. Any problem? So as you can see from the ICMR report also, from the last year 2017-2024, there has been no dip in the ceftriaxone resistance or ceftriaxone susceptibility, and antibiotics like ampicillin, ceftriaxone, and TMP-SMX have shown, along with azithromycin, have shown very good susceptibility reports, except for quinolones. Most of these antibiotics work fairly well. So we wanted to emphasize from this case was there is absolutely no need to switch to, next slide, switch to various other antibiotic combinations like piptazo, cephalosporin sulbactam, or even a carbapenem for enteric fever. Ceftriaxone works well for patients who gets admitted with enteric fever. And TMP-SMX or azithromycin is a good enough oral option for treating these patients if you are treating them as an OPD basis. Next slide. Now, case 4 is regarding the management of fungal infection, which also gives us a very unique idea about what is going on in our country. This is a 24-year-old male who has undergone haploidentical stem cell transplant for AML. He is on posaconazole for prophylaxis, develops febrile neutropenia, which is not responding to routine antibacterial agents, and cultures are negative. His CT scan has been done, as you can see from the photograph on the right side. There is a pleural-based shadow. Next slide. Pleural-based nodule, which is breaking through on the posaconazole. Next slide. So how to proceed? Next slide. So we do a serum galactomannan in the blood, which is positive, was 3.88, which was done in the blood. Next slide. We simultaneously send blood for culture as well as Aspergillus PCR. Aspergillus PCR picks up Aspergillus PCR, did not speciate, and it was positive. Next slide. So a probable aspergillosis diagnosis is being made. Yeah. So probable aspergillosis diagnosis is being. So what is the therapy of choice? Is it voriconazole or liposomal amphotericin B? Now, it might appear that, there is a general tendency to escalate antifungals to liposomal amphotericin B, which may work well in most of the situations, but this is an exception here. Next slide. As you can see from the report, close to around 300 isolates of aspergillus were studied. Most common species were flavus and fumigators. And what we found out was that nearly 1/3 of these isolates were resistant to amphotericin B, whereas voriconazole susceptibility was close to was 100%. So in India, if you are managing aspergillosis, it is better to stick to voriconazole only rather than escalating or trying amphotericin B. Next slide. Some other highlights are this is from the Pseudomonas. As you can see, quite around 24% of the isolates which were studied in this report were carbapenem resistance, and on genomic analysis they were close to around 27 isolates of these were MBL positive, or they harbored metallo-beta-lactamase. Next slide. Now, a lot of newer drugs like ceftazidime, avibactam, cefepime, and metazobactam, and ceftazolone, tazobactam have been developed, and they are available for use in India, but they are ineffective against MPL. Now, Pseudomonas is a notorious organism which harbors multiple and complex mechanisms for resistance. Next slide. So, it is better not to depend on the molecular test or enzymatic detection test to decide on antibiotics. It is suggested that in vitro susceptibility of the antibiotics which are supposed to be used is demonstrated, and then those antibiotics are given for these patients who are suffering from infections with DTR Pseudomonas. This is the genomic distribution of close to 300 isolates from pneumococcus. Next slide. And these are the vaccines which are available for pneumococcus currently in our country. Pneumocil 10 is an indigenous Indian vaccine which has been developed by Serum Institute of India and is part of UIP as well as recommended by NTAGI. As you can see, apart from one or two serotypes like 35B and all, rest of the pneumococcal serotypes are covered by most of the vaccines, including Pneumocil 10. Next slide. So the vaccine coverage is quite significant, and we don't see as of now non-vaccine serotypes constituting major part of pneumococcal infections. Next slide. Now, there are some pitfalls which are important to understand so that we can improve upon our work. One of them is underrepresented of few samples of clinical syndromes like diarrhea and meningitis. We did not have enough isolates of CSF or stool samples to make a very meaningful conclusion out of it. And as you can understand, this is an overrepresentation of tertiary care centers and does not generally recommend the holistic picture of India. But since they are tertiary care centers, so these reports are very good in deciding upon or creating a benchmark or deciding on empirical therapies or formulating antibiotic policies for hospital-acquired or healthcare-associated infections. But for community-acquired infections, probably more data from the community needs to be done. Also, a more deeper dissection of the data like age-wise data, pediatric data, neonatal data, specialty-wise data, hematology, oncology, surgical, medical, cardiology, all these specialty-wise data, comorbidity-wise data, and region-wise or type of healthcare type data. Dissection needs to be done before in order to interpret these reports much more wisely. Thank you.
Thank you, Dr. Nitin. So we have now been joined by our additional DG, Dr. Alka Sharma. She is scientist and heads the extramural program at ICMR. So, Madam, I warmly welcome you to this workshop with webinar leveraging AMR surveillance to bridge the gaps in clinical practice. And I request you to give your introductory remarks, please.
Thanks, Kamini. And respected Secretary DHR and DG ICMR, who is going to join with us very soon. And also the Dr. Kamini Walia, Head of Development Division, PHF. Extramural Division. So, as I just said that respected Secretary DHR and DG ICMR, so he has joined us now. And Dr. Kamini Walia, Head Descriptive Division of Extramural Research at ICMR, and her team, and all the participants who all have joined online and also in this room. So as you already heard the highlights of this network, and this antimicrobial resistant surveillance network is a national AMR surveillance initiative launched by ICMR in 2013. And the goal that you all have heard now of this initiative is to monitor resistance patterns in clinically important bacteria and fungi in humans and carry out research on how resistance spreads and develops. And it supports evidence-based policy making, has developed treatment guidelines, and promotes antimicrobial leadership. So basically, the highlights which have been shared by now, this is the opportunity I will take, that this is the occasion where you all can have this, leverage this opportunity and that participate in this workshop. And this is very, very important webinar for all of you to understand the details of this network and how you can leverage this for your own studies, and also how this is going to have impact on policy and also these guidelines in this particular area. There are 6 nodal centers. You all are aware of that. And also there are 16 tertiary hospitals lab across the India providing data. So with this background, now I request DG sir for his remarks. Maybe before that, we are going to release the for the agenda. So over to Dr. Kamini.
Yeah, thank you. Thank you, ma'am. Thanks for your introductory remarks. And I welcome Secretary DHR and DG ICMR, Dr. Rajiv Bahl, to this very important webinar. So as you all may know, Dr. Bahl is a trained in pediatrics and public health, and he has worked for many decades in maternal, newborn, child and adolescent health at WHO. In ICMR, he has initiated many transformative changes with emphasis on data-driven decision-making. So this initiative is very much in line with the DG's passion for evidence generation and data-driven decision-making. And we are delighted to inform you, sir, that this is the 8th report that we are releasing. And for last 8 years, the data management team and all our centers and also the PIs who contribute immensely to the quality data collection. This year, we have compiled the 9,000 almost isolates data in this year's report. And we request you to kindly release the report and then just...
Online release, online?
Yes, sir. Yes, sir. It has also been uploaded on the ICMR website. So Dr. Nitin Bansal, he is the ID physician with us in our network. He has already presented the highlights of the data.
Very good that you used that time. Otherwise, I was feeling very guilty.
So we can stop sharing this and we will now have your remarks, sir, and then we will go to the panel discussion.
Thank you so much, Dr. Kamini. Firstly, to this audience or this group of people, talking about importance of AMR is just not even necessary. We understand how important antimicrobial resistance is. We understand that we need a solution. It's not just knowing the problem or looking at the problem or understanding the problem, but we need to find a solution to this issue. However, the first thing about any problem, finding a solution, is to describe it and to understand it and continue to understand it appropriately. In this regard, I must appreciate the work of Dr. Kamini Walia and her whole team that has been going on for the past 8 years in maintaining surveillance across India in many tertiary care centers. But this year, we are doing something special. I hope you have also talked about that we, as she has told you, we have extended the surveillance to also secondary hospitals. So they are tertiary care hospitals, but they are secondary district level hospitals as well. That will be now part of this surveillance network. So this is absolutely necessary and important. We were other day discussing how important is, let's say, typhoid vaccine program. It will depend to a great deal on how much resistance are we finding, particularly multi-drug resistance, particularly resistance to azithromycin, for example, as we are moving on to third generation cephalosporins. If we start finding that, immediately it will be a change in terms of the need for the vaccine will grow multifold. So having a track of that is so critical for all these reasons. I just gave a very small example because that was in my mind a few days ago. This question was being asked. But we need to use this evidence in other ways, not just to track the problem of antimicrobial resistance, but first uses advocacy so that people think of AMR. People think that these antibiotics will not be there forever, that we think we have defeated the bacterial pathogens, and we have forgotten that they have existed on this earth nothing more about 3 to 4 billion years before us. And they are much, much smarter than all of us are in their own way, at least for survival. So anything that threatens to kill a microbe, a bacteria, it will find a way to survive. And they have survived worse things than antibiotics. So antibiotics are not going to be always able to control the bacteria. So if we don't use them sparingly and judiciously, we are going to be, the bacteria is going to get over this. It's a shock to them, but they will get over this. Right? So please understand that this is the philosophically evolutionary, in an evolutionary sense, they have survived much worse than antibiotics. And these pathogens will learn somehow to survive the antibiotics. And we are not finding them at a pace that can outrun the pace of evolution. Because there are not as many targets even. How many targets can you do? They don't harm you, but only harms a prokaryotic cell, but not a eukaryotic cell. Then the other use of this data, of these data, is to change clinical practice, to see what practice changes you can drive, not only advocacy in general for AMR and programs to eliminate AMR, but which can really influence clinical providers, clinical care providers to use rational use of antibiotics. It will also, these data will be useful. That should not be all. I think when I see people think about antimicrobial resistance, they only think about largely two things. One is measuring AMR, advocating for One Health approach in general of saying animal, human, this. And thirdly, in all that approach, largely it is rational use or sparing but correct use of antibiotics. Those are excellent solutions. But I also believe that these data should drive science. They should drive other ways of dealing with infection. My philosophical answer is that I want is something that will not kill. The greatest way to drive evolution or evolutionary resistance meaning evolutionary events that will get us, kind of more antimicrobial resistance is to threaten with survival the bacteria. We think bactericidal drugs are better than bacteristatic drugs, for example. Usually that is the. However, I am finding for my own father that eventually the only thing which is keeping him alive at 91 with persistent UTI is a drug which we think, which is Martifor, which is nitrofurantoin, which is a very mild bacteriostatic, but it is controlling it's the only thing which controls. You give him IV anything, after 2 weeks, there's another, the surge is back. So what I'm trying to say is that we also need to find other ways of dealing with bacterial infection than killing the bacteria. Because if you threaten the bacteria with death or you kill them, then it will mutate faster and find a way to survive. Some clone will survive and it will be the resistant one. However, if something like what we learned, maybe the nature learned to deal with bacteria, pathogenic bacteria, was to keep good bacteria. So the entire microbiota, that approach that the nature has actually taken is to keep away some of the pathogenic bacteria. We have millions of non-pathogenic bacteria. We nurture them. We give them the food. We don't give the food to the bacteria in our gut, in our lungs, in our skin, in every exposed area, in the eye, in the GI tract, in the genitourinary system. Nature has found a way to keep the right microbes so that it doesn't have to kill everybody. It only has to kill the ones that somehow surpass and get away. So in philosophy, if we can think about how to deal with infection without trying to kill the bacteria and make those interventions, that also should be driven by this kind of resistance, because we should learn that antibiotics are not the only way to fight infection. So I think this would be a great webinar to hear everybody about what their thoughts are, how to leverage AMR surveillance to bridge gaps in clinical practice, even if it is towards rational use of antibiotics. I raise this bar a little bit. I always say that science needs to go beyond this frontier. We should not be happy that we are measuring and we are saying antibiotic sparingly. We should also find other ways. Some of those also are not going to last forever, like bacteriophage. Again, it is going to try and kill the bacteria. Anything you kill, it will develop resistance to bacteriophage very rapidly. That is the whole CRISPR system, CRISPR-Cas system. It will develop some sort of quick resistance. So all the things, why do we have an antibiotic? Because of survival of fungi. So the fungi learned to survive, to keep the bacteria away. We took nature and then we understood something and we think we have cracked the code. But there is much more to it than we see. We will not be able to fight AMR. We have to find a way of biofilm, of something which will not let the pathogen go in. How do we get the right microbiota to use one bacteria against the other? And all the other successful evolutionary mechanisms that nature has against the bacteria. And therefore, my also plea to scientists is that think beyond use and think beyond this, only the surveillance. Thank you, and look forward to the rest of the discussion.
Thank you, sir. Thank you so much. And really appreciate your always motivating us to look for solutions from the data that we are collecting and not just become complacent about doing the surveillance well and gathering quality data. So now we come to the next part of this webinar, which is a panel discussion, and we have a very eminent experts here who will be participating in this panel discussion. The discussion will be moderated by Dr. Priscilla Rupali. She is ID specialist from CMC Vellore and has interest in enteric infections, transplant, infectious diseases, and antimicrobial resistance. Joining us on the panel are Dr. Mammen Chandy. He was formerly director of Tata Medical Center, Kolkata, and pioneered India's first bone marrow transplantation. In fact, he has always been very passionate and concerned about the patients who are undergoing treatment at hospitals, and Tata Medical Center was one of the regional centers that we had as part of AMR network. We welcome you, Dr. Chandy, to this panel discussion. We also are joined by Dr. Subramanian Swaminathan, Director of ID at Gleneagles Hospital. He is currently also the President of Clinical Infectious Disease Society of India. Welcome, Dr. Swaminathan. Thank you. We are also joined by Dr. Yatin Mehta. He is Chairman of Medanta Institute of Critical Care and Anesthesiology at Medanta Hospital, Gurugram. Grateful to you, sir, for giving time to this activity. And he has more than 40 years of experience of critical care and cardiopulmonary resuscitation. Then the next panelist is Dr. Balaji. He is a professor and clinical microbiologist at CMC Vellore, very prolific researcher, and also one of our PIs for our global centers. And he has contributed to national and global efforts on AMR. Welcome, Dr. Balaji. I also welcome Dr. Tanu Singhal. She's consultant at Kokilaben Hospital, and she has published in infections on immunocompromised children, HIV, cancer, primary immunodeficiencies, and manages routine pediatric illnesses. Next one is Dr. Saurabh Datta, Professor Newborn Unit at PGI Chandigarh. We welcome you, Dr. Datta. And his interests are neonatal sepsis, retinopathy of prematurity, probiotics, milk microbiome, and his team also showed shorter antibiotic courses can be effective in newborn infection. And our panelist from Shere Kashmir, Srinagar, Dr. Syed Mudassir Qadri, he focuses on pulmonary medicine, respiratory infections, and critical care. So I welcome you all to this panel discussion. You have already heard the highlights from Nitin. Many of you have been associated with this network, but some of you are not part of this network. We would really like to hear from you. What are the gaps that you see, and how do you want ICMR, what actions and steps you would like ICMR to take to plug those gaps, especially the data gaps. And now I hand it over to my co-moderator, Dr. Priscilla Rupali, to please moderate the session.
Thank you, Dr. Kamini, and good evening, everyone, and congratulations on the release of this wonderful surveillance network data. And I laud the efforts of ICMR in taking this forward and bringing such valuable data for clinicians to actually put in practice. So this webinar is aptly titled Leveraging AMR to Bridge Gaps in Clinical Practice. And I see that most of us here are clinicians. So I'll be directing a question to one particular clinician in turn, but please feel free to join in, add your comments, and I'm sure everyone would like to hear. I see a lot of participants. Please place your questions in the chat box as well. So thank you everyone for joining. So I'm going to start off with a question to Dr. Mammen Chandy. All of us look up to Dr. Mammen Chandy. Most of us have been his students. And so the first question goes to you, sir. You've been in practice longer than most of us. So, sir, hematology often has the sickest patients. And the most worrying syndrome that everyone worries about is really febrile neutropenia. And febrile neutropenia is one of the reasons where we actually see a very high rate of antibiotic consumption. So I have two questions for you, sir. So one is, what is your advice with regard to implementation of antibiotic stewardship in hemato-oncology and bone marrow transplantation? And the second one is, in your experience spanning many years, you would have noticed like there's been a remarkable change in profile of the bacteria in febrile neutropenia. The resistance has been dynamic, it's been changing. So in your experience, have you seen it negatively impact patient outcomes as well as costs? Over to you, sir.
Dr. Rupali, thank you so much. I want to say a few words before I get into the questions. One is that I want to thank Dr. Kamini for supporting Tata Medical Center and Dr. Sanjay Bhattacharya. I believe that he is doing fantastic work in helping us at Tata Medical Center, both with patient as well as environmental microbiology. Dr. Bahl, sir, I haven't had the privilege of meeting and talking to you, but I would certainly love to meet with you. I can't take your call now, okay? And Alka is somebody I haven't seen for many years, so it's a pleasure to see you again on the screen. A few years back, we had the person in charge of antimicrobial management in the UK at a seminar in Vellore. And she told us that the greatest threat to the UK would not be from cyclone or terrorist attack or fire. It would be from microbes. And you may have your child dying of appendicitis because there isn't an antibiotic. The second thing I want to say is that in India, we are worried about the medical side of it, but I think animal husbandry uses tons of antibiotics. I recently was trying to improve the water quality in a lake near my house, and a professor from IIT said, there is no groundwater in India which is not sewage contaminated. So I think the microbes are going to be there, and infection is going to be a huge problem. Yes, Rupali, infections, when you don't have neutrophils, can kill you. And your first line of defense against bacterial sepsis is your neutrophil. And when that's gone with chemotherapy or transplant, we have a problem. Data from Vellore, 2015, 24% induction mortality for AML with gram-negative MDRO being the cause in 50%. In most Western centers, AML induction is less than 5% mortality. In 2022, we published a paper from Tata in Calcutta in transplant and infectious diseases, and it was entitled Transplantation in a Zoo of Microbes, of Resistant Microbes. We are doing surveillance microbiology for transplant patients, and 85% of patients who go in for a transplant are colonized with MDRO. I'm even talking about a child from Hyderabad who has never been admitted into a hospital apart from transfusions. So in this study, 28% had positive blood cultures and in the peri-engraftment period, and there was a 61% correlation with stool surveillance microbiology. Answer to your question, yes, antibiotic stewardship with well-defined protocols on management of febrile neutropenia is essential, but these must be reviewed constantly with dynamic resistance data coming in either from your own institution or from networks. The most noticeable change that I have seen in the past 10 years at least is the increase in carbapenem resistance and the need to use ceftazidime-avibactam stroke aztreonam in patients who are neutropenic. In neutropenic patients, you don't have time. You have to get onto the sepsis quickly. I've seen a child in the morning looks okay. By evening, he's in shock. He's ill, ready to be shifted to the ICU. So infection is a significant cause of morbidity and mortality in neutropenic patients. And the two main diseases are AML and transplantation. Thank you, Rupali.
Thank you, sir, for your insights. I would welcome any insights from any other panelists if they would like to jump in. Dr. Bahl, Dr. Alka, Dr. Walia, please jump in if you think there is something you would like to comment on. The next problem I think we should go to is a ventilator-associated pneumonia. And Dr. Nitin very nicely presented some data which has been collected from ICMR. So my next question goes to Dr. Tanu Singhal. Dr. Tanu, we noticed that from the data that Dr. Nitin has presented, there is quite a bit of resistance, more than 90% resistance to carbapenems for Acinetobacter baumannii. And as you can see that most guidelines do recommend combination therapy. Cefiderocol, as mentioned in the ICMR network surveillance data, is not available. And we do not really have susceptibilities mentioned to sulbactam. So what potential therapies do you think would be useful in India, in your opinion?
Thank you for inviting me to be part of this panel. So the first is that polymyxins have to be there, because that is one drug to which there is almost universal susceptibility. I was surprised to see a high cholesterol MIC there, but if that was a Vitek MIC, I would have confirmed it by broth microdilution, because just wanted to know whether that was done. So that is one message, that cholesterol susceptibility should always be done by broth microdilution and not by Vitek. Now, because these polymyxins don't have very good penetration in the lung, we have to use another drug here. And we know from various trials that meropenem is not a good drug, because the outcome of meropenem-based combination was not better. In fact, it was inferior to the polymyxin alone. Now, minocycline is obviously the second drug which one would like to use. However, there is another point to be made here, that we normally assume that the susceptibility breakpoint is 4 for minocycline, for Acinetobacter. But new data is coming in that actually it would be a more PK/PD based breakpoint should be 1. I mean, so many times you should look at the minocycline MIC. And if your MIC is 1, then you are good with a dose of 200 twice a day, which should be the dose of minocycline which you should be using for your Acinetobacter. But if your MIC to minocycline is higher, like 4, though the lab will show that it is susceptible, it may not work. So that is another caution. So I think we should look at the actual MIC of minocycline. Tigecycline, again, the problem is that, again, though the lab shows the report to be susceptible, we should not use tigecycline, 1, because most of the times the MIC is more than 1. And second, it doesn't have good penetration in the lung. So that is why that is out. Now, TMP-SMX. I think Dr. Balaji will answer that question later. Sometimes the lab issues a report saying that TMP-SMX is susceptible, but in vitro it may be susceptible, but I don't think it's a great drug for Acinetobacter. So in the case which Dr. Nitin presented, whether the outcome was good because of minocycline or whether it was because of the combination, I'm not sure. Even though we don't have sulbactam susceptibility, we do use sulbactam in our regimes, because sometimes if minocycline is resistant, then there's no other drug to use. And sometimes we do get an indication from cefoperazone sulbactam susceptibility. So if the report says that cefoperazone sulbactam shows intermediate susceptibility, that is sometimes a surrogate to tell that sulbactam may be susceptible. So in my hospital, if I have an Acinetobacter VAP, and I find that it's only polymyxins which are showing intermediate susceptibility, and mino, TG, everything is resistant, then I add sulbactam, because there is no other drug to add. So that is what I would say, to use polymyxins and high dose minocycline if susceptible, and then if that is not, then add sulbactam to the regime. And cefiderocol is available. You can get it now easily, but it is very expensive. So daily treatment is in lakhs. So very few patients can afford it. But now that cefepime zidibactam is soon going to get marketed, that is going to be a good drug for treatment of carbapenem-resistant Acinetobacter. So I think once it is available, we should try and use that drug.
Thank you, Dr. Tanu. Over to Dr. Balaji for your comments. So, Dr. Balaji, apart from commenting on what Dr. Tanu has mentioned, I just have a few other questions for you. Of course, one is, would you agree with Dr. Tanu's choice? But the other thing I wanted to ask was, we are not really reporting Septran and Sulbactam susceptibility in the surveillance network. Is it because it's technically difficult, or what do you think would be ways to actually check whether these drugs would be useful in the treatment?
Sure. Thank you, Dr. Priscilla. I do totally agree with Tanu's viewpoints. Whatever she said, absolutely, it's correct. In addition, what I would like to add is ICMR, it's a complete surveillance network. So what we do is we consistently report for every drug, individual drug, susceptibility profile and resistant mechanism. So any synergistic test done, it's very difficult to do on scale. In this network, yearly we are doing almost 9,000 isolate from different. So that many number of, or even for 200, 300 isolates also, it's difficult to do synergistic test. So what we do is this combination testing. And in the combination testing, always in ICMR, we have decided that we don't cut short and do checkerboard, something like that. So we always go for the gold standard time kill assay. And it is quite tedious. So what we do is we randomly choose the borderline and resistant isolates with the different MIC values, higher MIC values, and all the possible combinations we do. And then we check, we give that findings as a publication. So as a publication, this information must be available rather than as part of this surveillance annual report. So I think even much before this annual report comes, the synergistic action, because these are all required for a patient treatment in real time. So as soon as possible, we try to publish and disseminate this news in WhatsApp and in our regular meetings. So coming back to Sulbactam, what we have done is we have done almost some close to 3,000 isolates Sulbactam MIC, and consistently we have seen the MICs in India, MIC 90 is above 128, which is different from US. The MIC 90 in US is 16 or 32. That's how the Sulbactam, Darlobactam, the combination can bring from 64 or 32 to 4. And it's susceptible, they can use. But in our setting, with the MIC 90 being 128, it's too difficult for that Sulbactam, Darlobactam to bring it down. And moreover, we have procured Sulbactam, Darlobactam, and with the Indian isolates, we checked, and it's not working, and it's not coming down less than 4. That's for sure. Then even IDSA guidelines says that you add imipenem to it. Even in addition to the imipenem, of course, we are the one, we told them that you need to use imipenem to effectively bring down to 4. After our, you can see from our papers, we have guided them that they should add imipenem. But after adding imipenem, to a certain extent, we can overcome, but definitely that's not the choice for Indian setting, because in India, in addition to OXA 23, we do have NDM also. So as Tanu was mentioning about the important role of minocycline, we have seen the combination of sulbactam and minocycline working very well. And because it bypasses the NDM, ADC, everything, minocycline, and sulbactam being the backbone of Acinetobacter therapy, actually it works very well. So that was good news. And if it is no NDM, to great extent, high-dose sulbactam and meropenem is also working well. So we generally don't encourage colistin for hospital-acquired pneumonia or ventilated-associated pneumonia. But if secondary bacteremia is there, definitely colistin helps. Even though it can't enter the lung, but still the bloodstream infection can be cleared. It can reduce the inoculum disease to at least moderate to mild, so that sulbactam and other minocycline can work very well. So definitely we have a good choice for Acinetobacter to handle as of now. And as you rightly said, Cefepime ziribactam, once it's available, And I think it should be available first in India than any other country. So that will really save a lot of lives.
Sure. Thank you, Dr. Balaji. So,
Sure.
the clinical practice, actually, most of us have been using polymyxin B and minocycline. And in vivo, it really works well. I don't think we see too many failures. So, but we do take your point, but maybe it is a matter of time. And probably there are better drugs coming. So sulbactam, which at a higher dose, definitely a dose more than 9 grams probably will be useful along with minocycline plus or minus polymyxin. So thank you for that.
One point I would like to add is now in US and Europe, they are trying to slightly go away from colistin and bring in eravacycline as a salvage therapy. And the success rate was quite much better than colistin because it is much better than minocycline. 4 to 5 times the serum levels are sustained. So eravacycline is the another drug which we should look forward for.
Sure. Thank you. Thank you, Dr. Balaji, for those comments. So just to bring to everyone in the audience that yes, at the moment for VAP, combination therapy is essential. A combination of polymyxin B plus minocycline is what most clinicians would use. It does work, but keep in mind that the colistin and polymyxin B levels are not great. So if you were pushed, you would actually think in terms of using high dose sulbactam along with minocycline could be a possibility till we have better drugs available. So, Dr. Balaji, the next question is actually for you again.
Sure.
As you know, strep pneumo is actually a pretty fastidious organism, and it's been difficult to isolate from CSF. And I think Dr. Nitin also presented that the guidelines that we're making for pneumococcal meningitis are actually based on 8 isolates of S pneumo in the CSF. And in these isolates, only 1 was actually resistant to cefotaxime. So the question probably I will ask somebody else as well. Maybe Dr. Tanu, I would like you to comment on this because you're a pediatrician as well. And Dr. Bahl, your comments are also welcome. So based on the data that we have, we find that only 1 isolate was actually resistant to cefotaxime. But most people would use a combination of ceftriaxone and or cefotaxime plus vancomycin. So are we right in saying that maybe in India, we don't really need to use vancomycin in addition? Or do you think empirically we would still add on and wait till targeted therapy is available? That is one question. The second thing is, why is it that we are not finding too many CSF isolates of strep pneumo, despite us having so many hospitals in the network? It's only 8 isolates. So is there anything we can do to increase the CSF isolation? So those 2 questions for you, Dr. Balaji.
Actually, I don't know where we found out that we are having only 8 isolates. Actually, we do have a lot of isolates coming in. So it's not necessarily CSF isolates, even bacteremic isolate with the meningeal symptoms are considered as CSF isolates. Meningeal symptom with the bacterial isolates is also considered as a meningeal isolate, and we interpret meningeal breakpoint, not the non-invasive breakpoint. So consistently, we were doing, CMC Vellore is doing for more than 30 years, and we could easily say that close to 60% of the penicillin resistant first step pneumo is there. But when it comes to ceftriaxone, it's around 10 to 15%. So it is a call by the individual doctors. If they are seeing more of that kind, then it's better to add vancomycin to ceftriaxone. Never ever vancomycin alone is administered. Always ceftriaxone has to be there and it has to be continued. In addition, you have to add vancomycin. And if the ceftriaxone is less than 1, there is no need to add vancomycin. If it is more than 1, then you have to add vancomycin. Because if you have only vancomycin and ceftriaxone not given, vancomycin is a big molecule, takes time, slow bactericidal. Because meningitis, it is a very critical infection. There should not be delay and prolonged illness. Very quickly, aggressively, it needs to be treated to avoid sequelae. So that's the reason they don't want to waste time. They suggest us to do the MIC on the same day for both vancomycin and ceftriaxone. And if in suspicion, you give both, then you can de-escalate once the results are available. So to be on the safer side, you can start both and then de-escalate it.
So
Thank you, Dr. Balaji. Yeah, Tanu, please go ahead.
yes, so I think you published that paper, Balaji, in 2017 or 2018, that is it time to change our empirical therapy for meningitis, where you said there were about 113 isolates where the penicillin resistance rates were about 40% and ceftriaxone resistance
Correct.
rates had increased to 25% in
Correct.
2018, of which one third were completely resistant. So I definitely emphatically feel that our empiric therapy for pneumococcal meningitis should be two drugs, because this is not a common infection that we are seeing. As a pediatrician or an adult physician, you would be seeing what, 2 or 3 cases a year, and this is a serious infection. So you are not going to be using it left and right. So you have a patient coming in with an acute febrile encephalopathy. Yes, the first drug you can give is ceftriaxone alone. You do your LP. If you find it is aseptic meningitis, fine. But if you find that the patient has bacterial meningitis, then you should give vancomycin, because you will be doing you will be using, let's say, an excess of vancomycin maybe 2 or 3 times a year, not more than that. And studies show that if your resistance rates are more than 10 to 15% in the community, there is a change in empirical therapy that is warranted. So that is why I feel that for a serious infection like meningitis, if the resistance rates have crossed 10 to 15%, then change in empiric therapy is warranted. And one of the reasons why we are not finding that many isolates may be because many of the patients receive antibiotics and then they come, and many times your multiplex PCR is positive, but your culture is negative. And therefore, you don't get idea about the antimicrobial resistance status from the PCR.
Sure. Thank you, Dr. Tanu and Dr. Balaji. So this was a question I remember somebody asking me. See, ICMR data only has 8 isolates, but you routinely recommend addition of vancomycin. So thank you for both of you for beautifully illustrating that pneumococcal meningitis is a very serious disease, and morbidity and mortality is extremely high, with resulting in result of neurological sequelae. So I think upfront, definitely empirically, vancomycin needs to be added on till you have further information available for targeted therapy. So thank you for that. My next question is for both Dr. Kadri as well as Dr. Balaji. So Dr. Kadri, Pneumocil is the Indian vaccine, the PCV10 developed by Serum Institute of India. And it covers, the serotype coverage is about 50% among children less than 5 years of age, and about 35% for those more than 5 years of age. But we do know that this has been a game changer to prevent pneumococcal disease in children. So do you think we should be including more serotypes in our vaccines? But the costs are huge, and the population that it needs to cover is also huge. So what is your opinion in that? And I'm sure you have treated adult patients who come to you with comorbidities, and this is a question probably that is asked to you as well. So Dr. Kadri, for your opinion, before I ask Dr. Balaji to comment on some other.
Mute yourself.
So am I audible now?
Yes. Yes, please go ahead, Dr. Kadri.
At the outset, I want to thank Dr. Kamini and the whole team for inviting me and doing such a great job. Of course, this vaccine, though, it will definitely prevent at least pneumonia from those 10 serovars which are included in the vaccine. But as we say, the world is changing. We have PCV13, now it has gone to PCV15, now PCV20 is available. Yes, we need to move forward. We need to increase the serovars in the vaccine to get more effectiveness. As we know, vaccines also help in preventing AMR, not just prevent the disease. They also help in reducing AMR, I mean to say. So it's very, very important that as the time goes, we need to increase the number of serovars of these Pneumocil, that's our indigenous vaccine, as we have to compete with, we know in the market, a few months back, PCV20 has come. And yes, now is the time when patient comes to us and the patient tells us, sir, I want the latest vaccine PCV20. So we need to keep pace with that. I just, because I'm from the clinical side, I just want to lay stress on one point, which is beyond your question. Just because it's the central ICMR team, I think there are a few things which we need to lay stress on. As I'm the PI for antimicrobial stewardship, which we are doing at this place, Sora. So I have found difficulty in treating pneumonia. What happens with us people? You will agree with me that ICMR says we should avoid using quinolones as first-line agents in pneumonia because of the high prevalence of tuberculosis in this part of the world. But what we see on ground, it is very, very difficult. People do write it, and we have seen people who come with upper lobe pneumonias or else, and we have seen they are already on quinolones, and we find they are AB positive. So I think we as a team need to lay stress. We need to spread this information that we need to follow ITSA, but here we have to follow ICMR. Because in India, the prevalence of tuberculosis is very high. By giving quinolones upfront, we see everywhere the resistance to quinolones is increasing very rapidly. And in case of tuberculosis, MDR is going to rise. So we should lay stress on this part. This was apart from the question.
Thank you, Dr. Kadri, for that comment. And Dr. Balaji, next question is for you. So is serotyping data of S-pneumo feeding in to create the customized vaccine for the country? So when Serum Institute made the pneumocell, was it based on the serotyping data, or did it actually change after pneumocell came in?
Actually, in India, as such, the surveillance information was very, very little, and it was only collected from 5 centers in the country, only in the metros, Vellore, then Mumbai, Delhi, not even Kolkata, then in another center in Lucknow. Nearly for 20 years, only from these 4 centers we had the information. Very little information we had. So really, we don't know across the country how it was. That is one reason. And second one is, as Kadri was mentioning, the 13-valent vaccine, we are not using it. Rather, we have gone back to 10-valent. And we were too late to roll out the vaccination because in US, they have started in 2000. Whereas government has approved in 2017, by the time the COVID came and the COVID went away, actually it's the intense phase of vaccination is happening in the last couple of years. So 22 years we are behind the Nemo vaccination. And now we don't use the best available vaccine 20, still we continue to use 10-valent. And the dosage is 2+1 rather than 3+1. So to achieve a herd immunity, it's going to take quite some time. It may take another 5-10 years. So the sooner we move to the 20-valent, it's better, but cost is another big factor which we need to think of. At least even this, if not 20, indigenously available 14 can be utilized. That will cover additional 4 more serotypes. The more the serotypes, it's better. That's what I feel. Otherwise, another idea is you give 2 doses and third dose can be primed with the PCV20 also in children. And now for adult, very fantastic MS-20 21 valent, which is more than 60% different from the child vaccine that's available. So actually both will complement very well for the adult separately and for children separately. But still we don't have even the adult protected by the common childhood serotypes because they are not being vaccinated. The entire cohort is vulnerable. So in India, as of now, in the last 4 years, cohort only is vaccinated with the 10-valent. And as a reference lab, every 3rd week, I am seeing some child died of some serotype which is not covered in the vaccine. So really, it's very sad to see that one. Every 3rd week I am seeing, because the pediatricians are so much aware about this serotype specificity. And the moment they lose the child, really they are shattered. And they were so curious to know what serotype. In spite of vaccine, I have a good number of child who have lost their life because that's not covered in the 10-valent. So it's nothing unusual that the 10-valent protects and all the vaccines, because definitely our surveillance also has to increase to more number of centers. Unfortunately, being a fastidious organism, even now, even after 20 years of effort, we could and few of labs only we can gather the isolates from. So none of the government setups in the India could give us pneumococci. It's all because of the corporate hospitals where blood agar plates are there. We could manage to get the isolates. Really, that is pathetic. Still, it has not improved. The infrastructure capacity building is a must for pneumococci.
Thank you, Dr. Balaji. So,
I just want to make a point here that even if you were to move from the 10-valent to the 14-valent vaccine, we are not going to achieve 100% serotype coverage. So it is just an incremental 10% difference. So if this covers 60%, that covers 70%. So even if you move to that, 30% gap is still going to remain. That I just wanted to make that point.
Yeah, sure. But
Yeah,
going to
because
20, it will be very expensive.
yeah, so even if you go to
I don't know.
20-valent,
Somewhere we have to take a
yeah, so
call.
even if you go to PCV 20, you will still be maybe covering 75% or so. You are
70.
not going to be covering
Sure.
100%. So that is a point which I wanted to make. So even if you give the best available pneumococcal vaccine to any child, we will still have people dying of invasive pneumococcal disease because they have not been covered by the serotypes in the vaccine.
sure. Thank you so much. Now, moving gears, we'll take one audience question. And the question here is, thank you for highlighting the expansion of AMR surveillance to secondary level hospital. One challenge is over-the-counter dispensing of antibiotics by pharmacists, which contributes to irrational use. So what practical regulatory, behavioral, and system level strategies are being considered to curb such practices? Dr. Kamini, would you like to take this question?
And just last week, we had a meeting on what kind of communication and awareness campaign should ICMR design for creating more awareness among different stakeholders. And we realized that the pharmacists actually come under the Department of Pharmaceuticals, and they don't directly come under the Ministry of Health. So, but now we have an action plan in place, and there will be definitely the communication and awareness activities which will be undertaken for pharmacists through different pharmacists association. They are also part of the national action plan, but definitely it is something that is a concern for ICMR, and we are looking into ways to handle it. Government there is a schedule H1, otherwise also antibiotics are all prescription drugs, but they are still available on the counter, and it is not time yet that India can ban the availability of antibiotics without prescriptions. So we are not there as yet. So education and awareness seems to be the only way going forward.
Thank you so much. Let's move over to the intensive care unit now. And this question is addressed to Dr. Yatin Mehta. So as you can see from the data that's been released, there has been an increasing trend of CLABSI rates. And among the organisms, of course, there's been a predominance of gram negatives, but also enterococcus among the gram positives. So what do you think is the reason for this trend, and what can we do to reverse it? And in your opinion, what would be a good empirical choice of antibiotics for suspected CLABSI? Dr. Mehta.
Thank you, Dr. Rupali. And at the outset, let me thank ICMR and particularly Dr. Walia for making this excellent presentation for 1 year data of AMR in India. It's very useful to us, and I think carry on the good work. Coming to your question about bloodstream infections, well, why we are particularly worried is because the bloodstream infection, the incidence is very high. See, 20 years back, I am a part of the INIC group of Victor Rosenthal, and we published that the rate of bloodstream infection was about 12 times more than the CDC data. Okay. 10 years back, we had published another large report from 44 ICUs, in the developing countries. And the bloodstream infection as such increased the morbidity by an odds ratio of 3.3, mortality. And the hospital length of stay was 14 days compared to 5 days. So I think it's a substantial drain on your system once the patient gets BSI. Now, your question of why we are what to do and why we are getting gram-negative infections more, because that reflects overall infection rate in the whole country, in every organ of the body, if you look at that. Gram-negative sepsis is a major problem in pneumonias, in bloodstream infection, in soft tissue infections, okay? Intra-abdominal sepsis. It's all gram-negative in India, compared to a lot of publications from the West about MRSA, which we don't see so much in India. But gram-negative sepsis, and particularly Klebsiella pneumonia, if you look at it, it is increasing all over. So this is as a percentage. If you gram-negative percentage goes down, then gram-positive will increase. Percentage will remain 100%. Okay, so that is the same. It reflects on your healthcare system. You should be particularly worried. There's been so much of discussion we had in the previous few questions about Acinetobacter. Now, if the Acinetobacter, I must point it out, if Acinetobacter is increasing in your ICU, there is a infection control problem. So kindly solve that and look into it. I freak out if two patients get Acinetobacter next to each other. I mean, I do not allow that. Or Candida auris, I mean, it's not relevant, but in a way it is. Coming to why this is increasing, also why we are getting high incidence of bloodstream infection is infection control practices are pretty dismal. Particularly, I'm sorry to say I'm addressing ICMR gathering, but there is data which shows public hospitals have a higher incidence of Acinetobacter than private hospitals. Okay, because the nurse to patient ratio is not correct. Hand hygiene, I think, is the cheapest modality of infection control which you can practice, which we don't do. Hub hygiene, leave aside following the bundles, insertion bundle, maintenance bundle for central line. We do not practice it as well as what should be doing. Blood collection, the way blood is collected is also not appropriate. In fact, I had a very high incidence of staph epidermidis infections in the blood cultures. I have 2 ICUs. I started using a phlebotomist, dedicated phlebotomist who does nothing else, does blood cultures. And the incidence of false positives came down substantially. The way the blood is collected, that also will make a difference. So I think that is what we need to do. I mean, bloodstream infection is a serious infection. Numerically, it may be third most important, because numerically, I think the urosepsis is the most common, followed by pneumonia, respiratory infections, LRT, and third will become bloodstream infection. But if you look at the price which the patient has to pay in terms of his life and in terms of his morbidity, in terms of the antimicrobial therapy which the patient is going to get, I mean, it is much higher than the other infections. Okay.
Thank you so much, Dr. Mehta.
Yeah.
Go ahead.
Empirically, you asked me a question, what would you use for bloodstream infection? I'll quickly, I understand you are running short of time, and I must congratulate all the ICMR guys. The government guys are sitting there at 7:15 patiently listening. So that itself is very creditable. Okay, quickly I'll answer your question about what is empirical therapy I'll give. If the patient has, I'm suspecting a prosthesis as a source of bloodstream infection, that means, as I said, hemodialysis catheter or a prosthetic heart valve or endocarditis, then my choice initially remains always ceftriaxone and vancomycin, depending on the renal function and monitor the levels and all that sort of thing. But if I have to give empirically for bloodstream infection, which is not related to these devices, but I get blood culture positivity, what would I give? Well, as we have seen the ICMR data, gram-negative sepsis remains the biggest problem. But about 30%, 25% would be gram-positive, so I'll have to cover both till I get a specific culture positivity. So I normally I would give carbapenem. Meropenem is the commonest one for gram-negative cover, and I may give any of the gram-positive cover. Although to be honest, I use either Tycoplanin, although it's not FDA approved, but it doesn't matter to me. Or I start using endogenously developed that levodopa diafloxacin. I have a few publications on that. That always works. And even the ICMR, your recent data shows that the sensitivity is almost 100%. So I've never seen a resistance to that. So that works quite well. But if a patient has a high risk of having CRE, he's been hospitalized recently, he's come from another hospital after receiving antibiotics, then as you've seen in the ICMR data, carbapenems are not going to work. So in that sort of a situation, it is a serious situation. So I normally use Cas-IV plus the S2NM combination. And then I'll wait for my cultures and I'll de-escalate when the cultures will come, along with the gram-positive cover, whichever you want to do.
Thank you. Thank you, Dr. Mehta. So gram-negative bugs are really common in the CLABSI infections. A lot of them have a lot of carbapenem resistance. Enterococcus is emerging as a CLABSI pathogen. So as you rightly said, meropenem may not really work in those situations. So most of us would start off with something like polymyxin B, along with something which would cover the enterococcus as well, would be appropriate looking at the data. My next question is to Dr. Saurabh Datta. Sir, there are 21 neonatal ICUs as part of the network, but we have not really stratified according to syndromes or age. So from the data that has been presented, do you think the BSIs among the HAIs are representative of what you see in the neonatal CLABSI infections? So what is the challenge that you face in extrapolating this data to your clinical practice in neonatal ICUs?
Thank you, Dr. Priscilla Rupali. And thank you to ICMR, Dr. Kamini, and the entire team for inviting me to this panel discussion and through me to give neonates a voice in this whole issue of AMR. So I emphatically feel that we should stratify according to age and syndrome, which, we always say that children are not just little adults. Taking that further, neonates are not just little children. They're an entirely different ballgame. And we do need, granularity of data and stratified data to help neonatologists and those who look after young infants. The reason is that, all the problems that have been mentioned so far, they probably get amplified several fold when you're dealing with neonates. Neonates are inherently immunocompromised. Preterm neonates are, 10 times more immunocompromised. There is probably more overusage of antibiotics in the neonatal age group than in any other age group. I don't know of any hard data, but that's my, gut feeling. The manifestations of sepsis, as you know, are protean in the neonatal period. There are a lot of mimics of sepsis in the neonatal period, which are very difficult to distinguish from sepsis, even when you use biomarkers. And, we are yet to really hit upon the ideal biomarker to be used in the neonatal period. So all this results in a vicious downward spiral, which is there in every other age group, but much more so in neonates. That the more multi-drug resistant sepsis you have in the unit, the lower is the threshold to start using very high generation antibiotics, and that fuels even more multi-drug resistance, and that keeps going on. So neonates are different than adults in certain other respects as well. The incidence of meningitis as a complication of sepsis is much higher in the neonatal period than any other age group. So about approximate ballpark figure is approximately 10% of all sepsis have meningitis as a complication. UTI also is a much more common complication in neonates as a consequence of sepsis compared to any other age group. And then there is hardly any localization of signs. Almost it's very easy for a pneumonia to become septicemia. It hardly remains localized to the lung. So I think having said that, broadly the trends of antibiotic susceptibility that are there in the ICMR data are applicable to neonates in a very broad sense, in the sense that, even we see mostly gram-negative bugs causing hospital-acquired sepsis. Even so Klebsiella, E. coli, Pseudomonas, Acinetobacter are the common organisms in the neonatal period. The carbapenem resistance is progressively increasing amongst all of them. We are, gradually getting to a stage where occasionally we are forced to use minocycline and tigecycline and so on. So broadly the trends are similar, but as for the reasons we have already mentioned, it would be very important to have separate data for neonates to guide informed choices.
Thank you, Dr. Datta. I think that is really a very valid point. We are becoming increasingly, we're looking at enhanced antibiograms as the way forward, because each group is different. Each syndrome has a different pattern of organisms. Each comorbidity contributes to a different predilection. So that point is well taken. My last question will be to Dr. Subramanian Swaminathan. So over to fungi, Dr. Subramanian. So the surveillance of Canada that has been elucidated in the AMR network, there has been a surprising and some considerable variability in the antifungal susceptibilities of Candida to echinocandins. And some examples that you see here are Candida parapsilosis, which actually has high susceptibility. And there has been more than 10% resistance in Tropicalis glabrata, and a little less, probably 9% in Candida auris. So given this variability, what would you suggest as empirical therapy in candidemic patients? Dr. Swaminathan, over to you.
Good evening. And first, let me congratulate the brilliant effort that's been put in by the ICMR team, both on my personal capacity and also from my parent society, the Clinical Infectious Disease Society. So candidemia and candida-based infections is becoming a bigger problem thanks to the widespread blasting of broad-spectrum antimicrobials, including gram-negatives. So it's rising lockstep with it. And the fact that we do have nosocomial candida spreading is also adding to this. Now, how do we handle drug-resistant candida? Azole resistance was not too much of a challenge because anyway, the guideline was recommending echinocandins as first-line therapy. But now with echinocandin resistance rising, it's becoming a little more challenging. Now, what is the cutoff at which we should be worrying about it is not clear. There's not clear guidelines on this. And there is also a lot of variability in the epidemiology of this resistance that's being detected. It's definitely more in certain areas as compared to other places. In my neck of the woods, echinocandin resistance seems to be fortunately fairly low. So one option is to probably go for a higher dose of an echinocandin, possibly even a double dose. The cost is a major issue, but toxicity-wise, it's not too bad. So that could be one option, at least initially while we wait for susceptibility testing and things like that. But I think beyond that, we will need more data on combination therapy, looking at flucytosine as combination and things like that. But I think that's, at this point, more of a Hail Mary rather than a generalized recommendation. And I think capturing more data, especially with experience on real-life situations, is probably the way to go.
Thank you, Dr. Swaminathan, for keeping that short and sweet. Yes, we are running out of time, so I appreciate the fact that you kept your time. I'd like to hand back over to our able moderator, Dr. Kamini Walia, for further comments and to the ICMR team.
Thank you. Thank you, all the panelists. Really appreciate your insights on how you handle the management of drug-resistant infections in your hospitals. And also, I think you highlighted the data gaps that ICMR should aim to plug going forward. I mean, it was heartening to see that almost 170 participants, they joined this webinar today. And there were different questions ranging from if for crab to know if it is NDM producers, should we routinely ask for carba expert, to which the answer is yes, and Dr. Balaji confirmed it. Then a lot of participants have asked about how are we planning to expand the data collection, which I already explained. We are expanding to the secondary level hospitals. And how can we use AI or ML for AMR trend prediction? This we are already working with IIT Mumbai on this to look at the disease burden estimations for the country. And there are some specific questions like robust data to suggest if levonedifloxacin as an empirical choice for gram positives. We will send these experts to questions to panel experts, and you can reply to them, and we will forward it to the participants who ask these questions. I was also glad to see that we covered a lot of topics besides just talking about drug-resistant trends. We talked more about the solutions, what kind of combinations we need, what kind of vaccine coverage we would like to see to prevent pneumococcal infections. also Dr. Saurabh pointed out about having data from all subpopulations. In fact, it was one of the sepsis meetings that we had, and we realized we have no data from the neonates on sepsis. That led to this initiation of expansion of AMR surveillance network to the secondary level hospitals in both private and the district level hospitals. And we also, I think, emphasized on the importance of infection control, because what we see is most of the time antibiotics are used to compensate for either absence of diagnosis or the poor infection control practices, especially in the hospitals as well as in the community. So with this, we come to the end of this panel, and I really thank all the panelists for their insights. Over to you, sir, for
No, thank you. It was very useful to hear. I only have one thought, that we should try and have more standardized protocols for management, because a lot of personalized kind of management also tends to increase resistance. So we should work towards that, to have standardized protocols. With regard to one comment that I heard, a lot of people in the government work from 8:30 to 8:30 every day. It is only not even the end of the day for some of us. So don't worry about it. Thank you.
We have DG's undivided attention only after 5:30 or 6. That's why I think it was a good idea. I request my colleague, Dr. Sonam, to give a vote of thanks.
Good evening, everyone. As we conclude this insightful webinar, we would first like to express our sincere thanks to DG ICMR for his leadership and continued support. We also thank additional DG ma'am for joining us today. We extend our gratitude to our distinguished speakers who share their expertise and perspectives on the importance of how the translating of the AMR surveillance data into a meaningful action at the bedside, within the clinic and hospital, and across the healthcare levels. Each year, we publish the AMR surveillance report, and which is made possible only through the timely and dedicated data submission from our both nodal and regional centers. We sincerely acknowledge their efforts and continued commitment to strengthening the national AMR surveillance. Our sincere thanks also goes to the data management team for handling such a big network, and so that we are able to publish and release only the quality data. We also thank all the participants for their active engagement throughout the session. Thank you once again, everyone, for being part of this webinar. Thank you.
And the report is now available on ICMR website. It is, you can see it under What New, and
posted the link on the chat.
Excellent.
Thank you. Thank you so much. Thank you. Thank you, everyone.
Thank you.
Thank you. Good
night, everyone.
Thank you. Good night.